say which year. And we're live.
Okay, so this is Senate Health and Welfare. We had a little technical glitch. We are back with Nolan, and we're going to listen and learn about Healthcare Systems 101. Nolan, thanks for being here.
Thank you. For the record, Nolan Langwell, Joint Fiscal Office. So this presentation is a presentation that I give to a lot of the Health and Human Services committees and the corporations committees as well, early in the session to kind of help bring people up to speed. It's meant to lay out the landscape and also help level set, because there's different levels of knowledge about what the system looks like. Their presentation should be posted, or if you want a hard copy, yes, Kiki could get you one. There's a lot of information in here. I'm not going to go through every slide, but it's meant to be sort of like a reference or an encyclopedia, so that later on you can refer back to how many people, blah, 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 how many hospitals do we have, et cetera, et cetera. So I might blow through some of these slides, and others I'll stop and talk more about. Feel free to stop and ask me questions as I go through the presentation. However, I will say that it's very easy to go down rabbit holes, and I may just stop us if it's going down a rabbit hole, or if it's something that I feel like, oh, I'll cover that in a later slide, or we're going to be covering that in the future. So I reserve the right to sort of pull us out of the rabbit hole. So I'm going to start my presentation here. Again,
Do you want any questions in between? How do you want?
Yeah, feel free to ask questions
Okay.
as we go. I think it's the easiest way, because it's relevant to the moment. So, oops. There we go. So the first, I start with a disclaimer. I try to use the most up-to-date data possible. However, there is a bit of a data lag there's always like a 2-year lag on a lot of this stuff, but there's a real serious lag right now, even more so, in two of the documents that I tend to use most for this high level. One is the Vermont Household Health Insurance Survey, and that's a survey that's done by the health department every 2 to 3 years. It gives us a sense of the landscape. How many uninsured are there? How many people are on commercial insurance? Why do people not have insurance, et cetera? It's a very useful document. It hasn't been done in probably 4 years. I don't think it's been done since the pandemic, so maybe even longer. That said, there is, I did see that it is being proposed in the budget adjustment to do so. So that's really good and helpful. And if it is passed, which I suspect it will be, they'll probably start contracting this summer, and then they'll probably do the survey in the late fall. And then we probably have the results by next January or February, just to give you a sense. But in the meantime, a lot of data is old. Second, and I'll flag different dates as we go along. So there's a lot of data, but the point still remains. The other document that I use even more so is this thing called the expenditure analysis, and it's done by the Green Mountain Care Board, who is the lead regulator of health care in the state. They also are like the data warehouse for a lot of this data. The expenditure analysis is generally done every year with 2-year lag. So we technically should have it up to 2023, but we don't. The most recent I think we have is 2020 or 21. And that's a combination of they were having some vendor issues and some personnel changes that kind of threw off their cycle. So it's unfortunate, but I understand why they're temporary problem, and they're working on remedying that. So I have to sort of premise that, because you'll see, well, that's 2020. No, that's pre-pandemic. That's during the pandemic. And I will point out where that is. But there's a lot of data in here. We want to always have the most up-to-date. I break this presentation out by patients, providers, payers, and regulators, just to give you a sense of how I'm going to be talking about things today. So very, very high level, as you know, we saw a population spike. In 2019, our population was 623,000. And in 2023, it was 647,000. So that's a large spike after having a long period of time of 0.2% growth. So the more people, it's going to change our coverage landscape and our spending landscape. The other interesting thing that happened was that between 2015 and 2016, our deaths surpassed our births in number. So later on, we'll see, well, why are costs going up? Well, there's a lot of factors, but a major one is we're an aging population. So as we get older, we cost more. Of course, there's a lot of other factors that play into that too, but that's a major one. So I'm just sort of laying the foundation of helping you get the local landscape.
And it relates to chronic illness in populations
Sure, absolutely.
younger as much as the really old people. Sometimes when you say that, people think automatically of really old people, but also thinking about acquired chronic illnesses and the associated costs.
You'll also see, so this chart, I like this chart because it shows 2010 and 2022. And you can see how there's been a shift in our age population. So you can see the number of those, our number of folks, our younger folks are lower than they were. And our older folks, there are more of them. So for instance, under 18, has you seen a big drop in that, and over 65, we've seen a big increase in that. So compared to, again, this is just sort of laying the foundation to give you a sense.
It's really great. 5 years older than the rest of the country.
I'm going to skip the vital stats. So we talk about providers. Who's our largest provider? Hospitals. You're going to hear a lot about hospitals this session. We have 14 hospitals in Vermont, one of which is a level 1 trauma center. That's the University of Vermont Medical Center. All of our hospitals are not-for-profit. We might be the only state that has all of our not-for-profits, or all hospitals not-for-profit. And that might just be because we're so small. There's 2 psychiatric hospitals. One is the Vermont Psychiatric Care Hospital in Berlin. The other is the Brattleboro Retreat, which is a private treatment center. Then there's Dartmouth Hitchcock, and that's in New Hampshire. And that actually provides a significant amount of healthcare to a large number of Vermonters. We don't know how many, but it is a part of our healthcare system. And yet, as you'll see later on, it's not a part of the health system we regulate because they're outside of our jurisdiction. So you'll see that becomes a theme of what we can regulate and what you can't. And then there's the VA hospital, which is another one that is federal government. So obviously we don't regulate that. I put this in here because I think it's useful, and this is going to be helpful in the conversations we have later on. But this is basically the percentage of the revenue, the net patient revenue for hospitals. So you can see that University of Vermont Medical Center accounts for 47% of the total net patient revenue to hospitals, followed by Rutland at 11% and CVMC, Central Vermont, at 10%. So you can see this, the University of Vermont Medical Center plays out a very large part of our system. They're trauma 1. It's in the largest county. They have the most beds. This is just to sort of give you a sense, and I'm not going to spend too much time on this, but this is just help you understand the sort of volume of the hospitals. So the total operating expenses for hospitals are $3.5 billion. There were a total of 238,919 visits to ERs in Vermont that did not result in admission. We had 44,000 discharges and 140,000 outpatient procedures. You'll notice that I have UVMMC again. We're listed in here. UVMMC, University of Vermont Medical Center. I'll always qualify my acronyms so you know what I'm talking about. Accounted for 21% of total ER visits. They accounted for a significant amount of our inpatient and outpatient days. But also you'll see that the inpatient, those age 65 or older accounted for half of all inpatient discharges, which means that half of the folks that were in hospital, admitted to hospitals were 65 or older, which means that Medicare actually paid 50% of the time. So a large part of hospital revenue is Medicare. Later on, we'll get into it and show that Medicare and Medicaid are different. I think most people know it, but I'll reiterate it over and over and over again. And by the way, it's okay to conflate Medicare and Medicaid. I did that yesterday in my presentation. I said Medicare. Oh, I mean Medicaid. They're so close in word. It's okay. But Medicare is pure federal. We have no control over it. We do not do anything. We can't control Medicare. Medicaid is state federal. We have a lot of control over our spending in Medicaid. So when we see Medicare, well, not much we can do about Medicare spending, except how we help keep that population healthy.
Yeah. Previous slide.
Yes.
Of the 238,000
patient visits to the ERs. Do you think it's possible to get the numbers on what those visits were for roughly? And then also what percentage of those individuals had insurance of some kind?
I don't think I can get it specific to the visits. I mean, probably could through Big Cares, but that's a lot of work for me to ask the Green Mountain Care Board to do.
Okay.
So, and I'll always qualify, like, sometimes data is available, sometimes it's not, but how bad do you want it? Because it does mean someone on the other end has to spend a few hours working on it.
Right.
So if it's a curiosity, if it's like, oh, it's supporting my bill. So
Okay.
I think that the answer is they probably could, because it's Green Mountain Care Board information, they probably could tell you what that's for, but it's going to be 12 pages long because there's going to be a million different codes, right? But it's also like, how important is it to you for me to ask that? We can talk about it.
I didn't know if you knew if those numbers were easy to get or not.
I think that they're available, but they would be probably time consuming for someone at the board to do.
Yeah, sometimes hospitals have some of that.
But
Yeah,
to
or
qual-
insurance, but
the flip side though is later on, I'll break out spending by payer. So I think it's less important about inpatient versus ER versus outpatient versus what is our total spending by payer. And I have that later in the slide, but I think you'd find more relevant anyway.
In my line of work in mental health, there's a lot of individuals that will visit an ER for non-emergent reasons because in
Absolutely.
mental health issues,
And I think they have that data too, how many people were non-emergent. So we can talk offline if you want more. Yeah, we can narrow it down. So there's in-state and there's out-of-state migration. We don't really have a whole lot of data on the number of folks that go seek care out of Vermont, which includes Dartmouth, Hitchcock would be a big piece of that. You know, it might be someone skiing in Colorado and falls and breaks their leg. We don't have any of that data. But we do have data on where they come from when they're coming to Vermont. So, and again, this is 2020 data. But, you know, of the hospital visits, 87% were Vermonters. 9.3% were from New York. That's most likely people coming over to either University of Vermont Medical Center or Rutland gets a significant amount of New Yorkers from the Albany area. And then we have Massachusetts, New Hampshire. So those might be folks who come from other states. And then you can see I break it out by the hospital and you can get a sense of like what percentage of each hospital discharges are folks that are not from Vermont. So you can see, for instance, Southern Vermont Medical Center in Bennington, 29% of their inpatient discharges are folks from out of state. Whereas Northwestern, you know, they go like in St. Albans or Newport, they're only getting 1 to 2%. So again, good for context. Another important part of our healthcare provider system are our federally qualified health centers. They're not hospitals, they're healthcare centers. We call them FQHCs for short. They're federally defined, and there is they have over 90 requirements to be considered an FQHC, and they include things such as offering comprehensive primary medical, dental, oral, mental health, etc. They have to be in a high-need area. They have to have a patient majority governing board. They have to accept all patients regardless of payer or ability to pay on a sliding fee scale, etc. So they're slightly different. They also get reimbursed differently from the federal government. They have a different reimbursement structure from how they get money from the federal government. And that also expands to the prescription drugs that they sell as well. There are 11 FQHCs, and they're located in 92 sites across all 14 counties. I guarantee you all have multiple FQHCs in your counties. And they've served over 198,000 folks. So you can see that they're an important part of our healthcare system, particularly our primary care. We have our long-term care. So this would include nursing homes. We have 36 nursing homes, 33 of which participate in Medicaid. We have 9 home health agencies, 18 assisted living residences, 85 residential care homes, and 9 hospice programs. Another important part of our healthcare system is mental health. Our mental health providers include designated agencies and specialized services agencies. We refer to them as DAs and SSAs. You'll be hearing from them at some point. The organization that represents them is called Vermont Care Partners. Then we have designated hospitals, the Brattleboro Retreat, and then the Vermont Psychiatric Care Hospital in Berlin. I'm not going to get into too much detail, but every state's different in how they provide these mental health services. In Vermont, the designated agencies and specialized service agencies were actually created in statute. And I sort of pulled out the statute so you can see what their role is and how the state envisions them being used in the system. Again, I'm not going to spend a lot of time on this. I just want to sort of flag that they are an important part of our mental health system. Like I said, there are 11 DAs and 7 specialized services agencies, and they're all across the state. We have designated hospitals, and those are hospitals that have inpatient psychiatric units. The Department of Mental Health currently designates 6 hospitals to provide that psychiatric care. That would be the Brattleboro Retreat, the Central Vermont Medical Center, Rutland Regional University of Vermont Medical Center, the VA, and the Wyndham Center at Springfield Hospital. We have the Brattleboro Retreat, which is a private nonprofit mental health facility. And then we have the Psychiatric Care Hospital in Berlin, which is Vermont's primary hospital for involuntary mental health patients. There's 25 beds and it's run by the Department of Mental Health. I'm going to skip through this. This is all meant to be reference. Read or refer to back later. So workforce, this committee and the committees in the legislature have had a lot of conversations about workforce over the last several years. And if someone who's in the system, you understand how important this is. So I try to talk about physicians, physician assistants, nurses, etc., dentists. So we have 3,100 physicians or almost 1,400 FTEs. Now I have both in there because we have 3,000 physicians, they're not all full time. So I think it's a more useful factor for us to know how many FTEs there are. And that's about 1,400. That includes 980, and that's not FTE, that number of physicians that provide telemedicine only. And it doesn't include residents and fellows, it's just physicians. About 30% of the FTEs provide mainly primary care. And then while there was a 26% increase in the number of physicians between 2018 and 2022, that translated only into a 2% increase in FTEs. So we might have seen more physicians, but maybe less hours. That's an important piece in terms of access. All that growth, by the way, was in specialty care. Primary care actually saw a decrease in the number. 20% of our physicians graduated from medical school or completed training in Vermont. Only 8%, small percentage, 8% both graduated from UVM-MC or the University of Vermont Medical School and did the residency here. 65% are 45 years or older, and 26% are 60 or older. So again, it gives you a sense of the workforce, where they're providing primary versus specialty, and sort of the age and the FTE. So it gives you a sense of our dire need. Yesterday, when I gave this presentation in House Healthcare, someone asked me, well, how many do we need? And there is a report out there that talks about the number of providers, not just doctors, but nurses and other folks, dentists, that we will need we need now in order to fully staff our healthcare system.
Do you know if that's a shortage nationwide or is it a Vermont specific thing?
I believe it's nationwide. It's particularly harder in rural states. We have our physician assistants. There was almost 300 FTEs, PAs, 32% were in primary care, 68 for specialty. There are no physician assistant training programs in Vermont, so they're all being trained out of state. 44% are under the age of 40, 45% are between 40 and 59, and 11% are 60 or over. So they're a little bit younger than our physicians, and they're helping to fill those gaps. Nurses, there are multiple types of nurses, as you know. We have our advanced practicing registered nurse, APRN, registered nurses, our RN, our licensed practical nurses, and then our licensed nursing assistants. They all have different level of credentialing, and that gets into an education that allows them to provide a different scope of practice. You'll see that we have, for instance, for the APRNs, we have 868 of those in practicing in Vermont, licensed in Vermont. 84% of those are actually practicing. So we have the number of licensed and the number of practicing. Not everybody who's licensed practicing. Some might be in administrative roles. Some might just be keeping their certificates fresh but not practicing. You'll see that the largest number of nurses are our registered nurses. The average age for all of them, except for the LNAs, is almost 50, 48, 49 years old. And yeah, so again, this is all 2019 to 2022 data, and this is just to help you understand like where is our nursing profession at, and yeah, even add in there how many are looking to expand to the higher level of nursing. I got all this from the health department who releases these workforce reports and all the different practices. Dentists, we have.
Can I, so we don't have, is there a report from the Department of Health on the number of travelers, or is that just sort of idiosyncratic, like this each hospital or place?
I don't think that's not in. Oh wait, actually,
Yeah, it's at the.
it's on there. Sorry,
Where is it?
it's a
Oh,
far
there it
right
is. How
column.
about that? 3%
Yeah,
and 10%.
but again, this is this is based on licensed nurses.
Yeah.
So what it wouldn't be able to capture is how many out-of-state nurses come in. Right, I don't believe that this report can track that. I think it tracks since it's asking Vermont and licensed nurses, although I don't know how they did the report. So maybe they, I don't know how they surveyed it.
But they're there, and we know
They're
it's
there.
expensive here.
Yeah.
So we have almost 400 dentists or 300 FTEs. Bless you. So most of them do mainly primary care. Again, we have a workforce, 30% were under 40, 40% were 55 or older, 18% were over 65. 30% of those are solo practices. Between 2017 and 2021, the number of dentists actually went up, but there was 14 less dentists that were providing at least 30 or more hours of care per week. So we might have increased the number of dentists, but the number but they've reduced their hours. And then while most are accepting new patients, only half are accepting new Medicaid patients. Payers. We're going to start getting a little closer to your question earlier. This is more very high level, just sort of give you a sense of where are people covered. 49% of Vermonters have private insurance, 24% have Medicaid, 21% are on Medicare, and 3% are military. This is from 2021. I don't think it's probably changed a whole lot. Medicaid might have gone up 1 or 2%. Medicare might have gone up 1 or 2%, but the chart's going to look roughly the same. If you took the numbers away, the colors wouldn't move a whole lot.
Are you going to categorize the private insurance
Yes.
further?
This again is also an older slide, but I like it because it points out a trend. The bottom blue, we see 60%. That is folks who have commercial insurance. The top two, the top one is Medicare, and the second one is Medicaid. When you combine Medicare and Medicaid, that's government insurance. You can see that in 2008, it was 30% of insurance people insured were on some form of government, and 60% had commercial. Fast forward to 2021, 45% are some kind of government, and the number of commercial has gone down. So you can see there's been a migration of during that period of people from commercial insurance to Medicare and Medicaid. Now, this the most recent is 2021. This is all sort of pre and during pandemic. We know during pandemic, there was a period of time where people who lost their jobs were going on to Medicaid, and then if they got new jobs, they weren't coming off because of this thing called redetermination at the federal level. So what we don't know is where does that look like today? Post-pandemic, has it sort of reset? Are there more people in commercial and less on Medicaid now? Or is it the same? We don't know. But this was a trend that existed prior to the pandemic. So
Is that trend primarily attributed to the aging population of people going on to Medicaid as they get older?
I think that there are a lot of things. I don't think we can pinpoint one thing, but I think aging population is a major factor. Also, a major factor is in that period, we've expanded Medicaid services and eligibility. So there's a little bit of that.
Is there any sense as to why or any reasoning why the uninsured numbers have gone down? That's interesting.
So Vermont, Vermont had made a lot of efforts, you know, through the Affordable Care Act and all that stuff to try to get the uninsured rate down. And I think they've been able to hold it for whatever reason. We were tied with Massachusetts for a long time for the lowest uninsured rate. I don't know what it's at now. I don't know if the uninsured rate's gone back up. We don't know how that sort of the pandemic shook the snow globe up a little bit. We don't know where people landed. But that was sort of the trend. Vermont had been very generous. The Affordable Care Act played a huge role in going from 8 to 4.
Thanks.
This also is a little dated, but the theme is still going to be the same. If you look at government, again, that's Medicare and Medicaid versus commercial, what services are they paying for? And so I find this interesting. If you look at like mental health and other government, it's almost 100% Medicare and Medicaid. Home care, home health, mostly probably Medicare and Medicaid. Nursing homes, stay in Medicare and Medicaid. But then you start getting into physicians and hospitals, it breaks up to almost by half. And then you start moving into like dentists, it's almost all commercial. So I found that really interesting to see like what services are the different payers sort of dominate. I don't think this is from 2022. This is actually 2020 data. I don't think this is going to change much. So now we start talking about, okay, our private commercial market. Again, I'm talking Medicare, Medicaid, military, commercial. That's how we've sort of broken down. I'm going to start kind of breaking down the commercial private market a little bit. And we have, there's several ways to categorize it. We have our employer-based, which is mostly self-insured or insured large group. I will get into the definition of what that means. We have our small group, which is also employer-based. Again, I'll define those in a moment. Then our individual market and military. The ones that have a star next to them, those are the markets that the state of Vermont has some kind of regulatory power over. So we regulate large group market, we regulate small group market, we regulate individual market. We don't regulate the self-insured, we don't regulate military. So this will start giving you a sense, and this next slide kind of lays it out. When you think about the scope of influence of the legislature, you can see, okay, well, we have Medicaid, right? We control the Medicaid budget, and we have a lot of flexibility about what we do and don't cover. And I'll get into that a little bit later. And then the individual, small group, and large group. But you can see there's a large population of Vermonters that the legislature really has no regulatory power over. We've done legislation that tries to, reduce those numbers a little bit, like try to get more uninsured people into insurance. But there's nothing we can do about Medicare. We can't obviously regulate military, and self-insured. So I like to throw that in there to give you a sense of your scope of power.
We haven't got it.
Well, when you think about it, we want to do stuff.
We do.
Well, this gives you a sense of, well, this is really how much of the population that when you make legislation, does really, can you really affect? Around insurance company.
Yeah.
Approximately.
Well, how many insurance companies do we have in the state of Vermont?
You
know, we have Blue Cross Blue Shield.
So the answer is complicated. There are a lot of companies that operate in Vermont. Probably over 50. And this, they might have as many as 7 people, but there are 2 providers that have almost 90, maybe 80 to 90% of the market. And that's Blue Cross Blue Shield of Vermont. We've got here who represents them. And then MVP Health. Blue Cross Blue Shield, by the way, is the only Vermont-based health insurance company. MVP, which has the second largest presence, they're based in New York. And then Cigna would be the third. And they're based out of Connecticut. But approximately 49% of Vermonters have private insurance. Now that number may have changed a little bit, but it's still going to be in that, you give or take 3%. So this slide is really meant to just sort of show you what is that when you take that piece of the market, just the private insurance, the gray section, how do they break out? So 74% of our private insurance market is self-insured. The rest of that group, you'll see the second largest is the small group, the large group, and other. And someone asked me today, who are the other? And I didn't remember, and I looked it up, and now I remember. Most of those are people who are covered by out-of-state insurance providers. So they're not buying through the individual market, they're not buying through the small group market. They're getting insurance from out-of-state. It could be, their employer. We don't know. They're not captured in our net when we're trying to regulate or trying to calculate.
Can you give us a few examples of who's in the small group and the large group? Oh, okay, cool.
Yes.
Thank you.
First, I want to talk about the insured versus the self-insured, and I'll get into the small group, large group in a second. So it's kind of a weird word, insured versus self-insured. And the best way to think about that is like a normal insurance product. You think about it like you go out or your employer, they buy an insurance premium for they pay an insurance premium for their employees, or you're on the individual market and you buy it for yourself. I'm paying the insurance company a premium for them to assume my health risk, right? And the insurance company, that's what they do. They're assuming risk. What self-insured are is usually it's a large company who says, you know what, I think that we have a healthy population in our workforce. We have all these wellness programs. Rather than pay the insurance company, we think that we can manage their health. And we will pay them. So we'll assume the risk of their claims. So they still might hire Blue Cross Blue Shield or MVP or Cigna to be their third party administrator, basically administering claims. So you might be a self-insured employer, like work for Global Boundaries, for instance, or the University of Vermont Medical Center, or even the state of Vermont, which is a little bit different. So I won't use it as an example.
PSEC.
Yeah, VSAC. You'll have a card that says Blue Cross Blue Shield on it, but those particular companies are self-insured, which means that Blue Cross Blue Shield is administering the program, but they're not assuming the risk. The risk would be on the employer. So if you have an employee who has cancer and they have $500,000 in claims, the company's paying it, not the insurance company. So that's the difference. But the other big difference is that we don't regulate, the state can't regulate self-insured. It's captured under a separate federal statute. I'm not supposed to say that loud.
Cancer.
You can, but that, and as you saw earlier, 74% of the commercial market are self-insured, and we don't regulate them. So just again, high level, insured means that the insurer bears the risk. Self-insured means that the employer or the company is bearing the risk and just using a third-party administrator. State is sort of a weird self-insured. They're slightly different. They're not under, but again, the state's assuming the risk, and I have a Blue Cross Blue Shield card.
What about educators? We hear about that a lot.
That's a good question.
Educators, they're part of this thing called VHIVE, the Vermont Education Health Initiative. And they were more like an association which is different. They're not self-insured. They're not, it's,
Intermunicipal Insurance Association.
thank you.
I didn't hear what you said.
Jen Carvey, Legislative Council, they're regulated as an intermunicipal insurance association under a different statutory framework.
Like VLCT, no.
It's just what it's called.
Just what it's,
And
okay,
it's,
got it.
and it's
Go ahead.
overseen by DFR. And they also use a third-party administrator and they pool risk in their own pool.
But it's slightly different because it's multiple employers. So each employer or every district might have a different percentage of the premium they're doing, or some of them might have an HSA or an HRA. So they're all operating slightly different within that risk pool. It's complicated.
Thank you.
It's more complicated, what we
It's even more complicated
Yeah.
than that.
But the good thing is finance.
That's right. Yay.
Yeah.
I'm not getting it.
We're gonna have to have a conversation with finance about that. one.
Yeah, right.
So this is like, I have a bunch of these quick notes. They're more like side notes, sidebars. The Health Benefit Exchange, we talk about the exchange, we talk about the Affordable Care Act. There's this thing called the Health Benefit Exchange. We call it Vermont Health Connect. I think most of everybody here is familiar with it. But it's an online marketplace for the individual small businesses to purchase their health insurance. And it's administered by the Department of Vermont Health Access, which is basically our state's Medicaid agency, and they're part of the Agency of Human Services. Now I'll get into the weeds of small employers versus large employers versus individual. So small employer is defined as up to 100 employees. So it's an employer that has up to 100 employees. There are approximately 37,000 people who are covered by these small group plans. This is actually pretty recent data. This is from June. Then we have our individual plans. So there are approximately 34,000 people who are covered by the individual plans. 82%, that's the blue below on the right, have some form of federal or state assistance to help with their premiums. And I won't go to the weeds about who and how and what, but it's based on their federal poverty level. That's what the charts are. Their eligibility is based on that. Then we have about 6,000 people that just buy through the individual market but aren't receiving any kind of subsidy.
So this is contemporary, I mean, relatively compared to the June 23.
Actually, they're both June 24. I don't know why.
Okay.
I should fix that. Yeah. Now, some of these slip through the cracks. That's one thing. Fix that.
Where is it here?
It says June 23. It's June 24 in terms of where this data is from.
Yeah, because there's.
Yeah, and on the right, I just didn't carry the one. So there are approximately 16,000 folks, 3% of Vermonters have military coverage. This is from 2020, but again, it stays pretty steady. This number hasn't really changed much over the last many years. And then are uninsured. So this is a number that I would like to know. The most recent we have was from 2021. We had a 3.1% uninsured rate, 19,400 people were uninsured. The interesting about this, though, is that 20% of those folks that who were uninsured were eligible for Medicaid. 52% of those folks were eligible for some form of state or federal subsidy through Vermont Health Connect. And another 33% had access to employer-sponsored insurance. So a large percentage of these folks that were uninsured had access to some form of insurance, but chose not to. And so one of the beautiful things about the Vermont Household Health Insurance Surveys is, well, why not? And 51%, as you were not surprised, cited that cost was the primary reason they did not have insurance.
Surprise.
So a lot of times they are people who are young, and young, we call them young and invincibles. But if there's other circumstances for why people don't have health insurance.
So that was actually me when I started my job in mental health. Yes, it's the cost, and then my company also gives a rebate. You just get a check for not having their insurance.
Yeah.
And I'm young and I'm invincible, so I get a check in the mail and my paycheck isn't garnished. So win-win. So I understand.
Yeah. And that's why when I remember, oh gosh, under 15 years ago, Jen, I remember the House Healthcare Committee saying, how do we get to zero? And the answer is you'll never get to zero. Unless you just automatically cover everybody whether they want it or not. You're never gonna get to zero.
Unless you have universal health care.
No, even.
Yeah, even then you might not.
Yeah, people will.
No, when we started, we were up 7 or 8%.
Yeah.
And I had one gentleman call that tell me, well, why should I get insurance? My son racked up his motorcycle, ended up in the hospital, and he didn't have to pay a thing.
Yeah.
The hospitals have to cover you. They have to provide you care whether or not you pay for it. And so that's.
Yeah. So there's a lot of reasons why people don't have health insurance, and there's always going to be those people who just like, I don't want it. Children.
Follow up on what Senator Cummings said, if so, in the event of that particular case, who does pay those bills?
So there's the hospitals have different.
Yeah.
Hospitals have different policies around charity care. Sometimes they'll just go to bad debts and the people just won't pay.
But the cost eventually gets
Yeah.
shifted on
Right.
to the insurance.
Every situation is slightly different, but every hospital has charity care policy where they'll reduce the cost for people who are unable to pay. But every hospital also just has bad debt.
We will see a medical debt bill
Yeah.
coming in. It'll be, Ann and I will be introducing it together. I don't know where it goes. We'll look at it here and we'll look at it there. You'll look at it.
Do we still have any of those religious groups that we're doing?
Yeah, Jen's shaking her head yes. I know.
Okay, and Sarah's shaking her head, yes, so I guess that's the.
What is it? I didn't hear that.
There's not a lot of,
Religious.
Sharing ministry.
Oh, right.
Ministry.
Yeah. I forgot about that. Yeah.
And
They'll
more
be-
common than you think.
Are they really?
Yeah, and
Yeah.
sorry, Sarah Teachout,
Go ahead.
Boston Blue Shield of Vermont. A lot of times, I think on the survey answers that you're talking about, people with healthcare sharing ministry coverage believe that they have health insurance. It looks and acts a lot like health insurance.
We're talking
They
about that.
talk about it like health
And it's-
insurance.
they probably fall under that other category as
Yeah.
well.
That'll be something finance could help us out with. Or can we help out with it? Sometime next year.
I haven't heard from them in a couple,
Me
probably
neither.
since COVID, and and it was a big bankruptcy in Massachusetts, I believe, and one of them went belly up, and there's news coverage that people weren't covered, and I know we don't allow insurance agents to sell them or refer them. And we're trying to be very clear that they aren't insurance.
You're raising some questions here, but Sarah, go ahead, one more comment.
One more comment. I believe that the Department of Financial Regulation is going to put a proposal in to have these entities report to DFR about, the number of members they have and how much they're selling.
So, and I think raising the question as we go through medical debt and who's covered under that bill will be important as well.
So this is a radical, I'm gonna pull us back.
Yeah, that's exactly what I said. One more comment. Thank you, Nolan.
Yeah. Another interesting fact is that, again, it's from 2021, but I don't think that has changed a lot. 52% of Vermont kids are on Medicaid. And that's largely because not necessarily that we have a lot of poor kids per se or low income kids, but we also have very generous policies about covering those kids, more generous than we have for adults. For instance, some of our CHIP or other programs will cover kids up to 300% at federal poverty level, which is Senator Cummings, 47,000. It might be
47,000.
that's for individuals. Yeah, so obviously for kid it'd be 34. So about 60,000 per family.
Yeah.
So, not that that's high income per se, but, For adults, we max out at around 133% of federal poverty, where with the children, we go up to 300%. So part of it is that we just have very generous. And also, so some of the programs for the premiums for kids are very low on Medicaid. For instance, under CHIP program, there's about 4,000 kids on CHIP. It's the premium is around up to $60 per family. So if I have one kid, it's $60. If I have 4 kids, it's still $60. So we have Vermont has made a point of trying to has some policies around trying to cover as many kids as possible, or having as few uninsured kids. As a result, there's 1% of kids in Vermont are uninsured.
Where's Dr. Dinosaur in this?
So if we talk about children on Medicaid, that's not Dr. Dinosaur. Dr. Dinosaur is the umbrella name for our Medicaid program for kids. So anybody under the age of 18 who's on Medicaid is under our Dr. Dinosaur. Now, I'll get into this when I talk about Medicaid, but to get in the door of Medicaid, there's different pieces of eligibility and how we count them behind the curtain or how we get federal match. The family and kids, they're not concerned with, it doesn't matter to them. All they know is they've got Dr. Dinosaur and then they've got coverage. So.
And it covers dental for kids?
There's pediatric dental, I believe. But adult dental has some limits.
Yeah.
It's like there's a cap.
Yeah.
It's like 12 or 13.
Pediatric dental, Dr. Dinosaur is basically anything that a child needs.
And didn't we just raise,
We did.
my last pass through because he couldn't even get a cleaning for one
We
Medicaid.
did increase it quite a bit.
Yeah.
But so this is my caution. Medicare and Medicaid are different.
Oh,
Yes, I think everyone here knows this, but I will say it again, because you never hear it too many times. Medicare is all federal. Eligibility for Medicare is different. It's all incomes. It doesn't matter as long as you're 65 or older. For under 65, it's certain kids with certain disabilities, and then there's any age if you have end-stage renal disease. I'm not sure the history of the carve-out for that, but it is quite a debilitating disease.
It's expensive.
It's expensive. On Medicaid, it's a state and federal program. It's primarily for lower income individuals, children and adults, or 65 and older who are age, or 65 or older, blind and disabled. So in short, it's for folks who are either a lower income or have some form of disability that helps them or allows them to be eligible for the program. So again, Medicare is a federal program. There's approximately 120 to 130,000 Vermonters who have Medicare, as we talked earlier, it's 21%. Most, which is almost 90%, are over 65. And then we have 1,500 kids who are 17 and under that are on Medicare because of some form of disability. I'm not going to get into the structure, but there are Part A, Part B, Part C, and Part D. I just put this in here again as a reference encyclopedia or whatever for you to go back to later on. And then now we'll talk a little bit about Medicaid. I'm pretty sure I'm coming back in, Senator, to talk about Medicaid more specifically, right? Okay, tomorrow. But some of this stuff I'll cover again tomorrow, but you can never hear it over. You can never hear this stuff so much. And the sort of joke with Medicaid is that if you've seen one Medicaid program, well, then you've seen one Medicaid program. And that joke may not be funny to you now, but as you understand, as we get deeper into Medicaid, you'll start seeing, oh, that makes sense. Because every state manages or operates their Medicaid or administers, by the better word, their Medicaid program differently. And that might be eligibility. We've done a lot of expansion. Some states haven't. And it might be services that are provided. For instance, in the later slides, you'll see I have mandatory services and optional services. So every state that has it has to have the mandatory services, but they might not cover the optional. Again, Vermont is quite generous. And then finally, we all have different federal matching rates. And then we have these things called waivers, which I'll get into a little bit more detail in a moment. If you're on Medicaid, you don't know that you're Dr. Dinosaur, or you don't know, you just get this card. That's Green Mountain Care, just like I get a Blue Cross Blue Shield card, right? So this is your card. And all that matters is that you can go to the doctor and get coverage. It doesn't matter how much the state's paying.
We just lost your, thing.
It's weird. My internet is unstable.
Ours is good.
Yeah.
Remember that seat?
That's right.
It's that seat. It's that corner of the table. We always blamed Senator McCormick because he was a Luddite. And then I got into that seat and they came down and there is a bad coverage in that corner.
I remember.
The whole finance committee then discussed that.
Is that better?
I didn't try it. How's yours? But there was some,
Yeah,
I don't know if it's a steel post in the wall or what's going on.
there you go. It's back. It's back.
Okay, so. Nationwide, there's about 80 million people who are covered through Medicaid or CHIP. CHIP is the Children's Health Insurance Program. So CHIP is actually not technically Medicaid at the federal level. It is the Children's Health Insurance Program. It's under a different federal statute. In Vermont, however, we administer it as part of our Medicaid program, and even more specifically, as part of our Dr. Dinosaur. If you're on CHIP, you are on Dr. Dinosaur. So we consider them in Vermont as, and we count them as part of our Medicaid program. But at the national level, they're not technically Medicaid.
Many years ago, we did Catamount Care.
Yeah.
And that covered adults. Was it Medicaid that only covered adults with children?
No, Catamount was pure. You're thinking VHAP, or are you thinking?
No,
Because Catamount was the public-private,
Yeah.
private insurance.
yeah, but it covered adults, lower income adults without kids. And then it went away when Obama
ACA.
was, yeah,
Yeah.
Affordable Care Act
Right.
came in, because we had covered, recognized the need,
Mhm.
and then it got caught up in the single payer discussion.
Yeah. And a lot of the families that were on Catamount, the parents would be on Catamount, the kids would be in Dr. Dinosaur.
Right. That was, I guess that was the group we were aiming at. The
Yes.
people without children who were probably made too much money to be on Medicaid, but not enough money to afford private insurance.
And a lot of those folks, some of those folks, when Catamount went away, they either came into the new federally defined expansion population.
That's what I thought when it,
Or I would say probably more, or at least a larger chunk of them also went to the exchange with heavy subsidy. Or not heavy subsidy, but with subsidy. So that's why another example, like we shook up the snow globe and people sort of sprinkled into different areas. So some people paid more and some people paid less. In Vermont, we have 197,000 people that have some form of assistance on Medicaid. Now, this is a point that I often drive home. If you hear that, or if you're talking to the media, or you hear somebody say, a third of Vermonters are on Medicaid. Well, that's actually technically incorrect. A third of Vermonters have some form of relationship or coverage through Medicaid, but not everybody's their primary. So 151,000 Vermonters, or approximately 26%, have Medicaid as a primary. So it would be safe or factually correct to say a quarter of Vermonters are on Medicaid. But to say a third aren't on Medicaid, because the other folks, we say partial assistance, those are folks that actually have their primary elsewhere. For instance, they might be on the exchange and they're getting a subsidy, but they're getting a subsidy through Medicaid. Or they might be they're on Medicare, but they're getting prescription assistance through our VFARM program. So that's why I'm always very particular about how you say things so you're factually correct. So again, and I don't think these numbers have changed a whole lot. But again, a quarter of Vermonters have Medicaid as their primary, and 1/3 of Vermonters have some form of relationship coverage, whatever, with Medicare. Medicaid. See, I did it myself.
Can I tell you how I remember what Medicare is?
E stands for eligibility,
Yeah,
elderly.
elderly.
Yeah, well, someone else said that the other day.
Yeah, it just, yeah.
I know the difference. I just keep feeling like, man, I mean, like even it's like, so they're so close. It's just like, even I say the wrong word. It's like when you call your children Steve, hey, Bob, you know, you know, yeah, you, what is your name? You know, that we all do that. So eligibility, who is covered, in order to have coverage in Medicaid in Vermont, you have to be a Vermont resident. You have to be a US citizen, permanent resident, or a citizen, or a non-citizen with lawful presence. Your financial situation would be characterized as low income or very low income and be one of the following, which would be pregnant, responsible for an 18-year-old or younger, blind. I think my battery just died. No, it's about to go.
Oh,
What's the trouble?
My battery just died.
Oh,
do you want me to go get you a?
do we have a cord in here? Yeah, we should have a connection.
Something,
Table.
well, it just crashed.
We gotta get that set up in here. We need everyone to have access
Yeah, it was,
at the table.
when I got here, it was 50% battery, so I don't know why it died so fast.
Yeah, mine only goes down like 20% for 2 hours.
Oh, this won't work.
Is it?
Oh, no, this will work. This will work.
Okay.
It'll work.
I'm not bad.
Give us,
Can we save it?
yay. Give it a second. It's gotta go. Oh, okay, so the technical difficulties, we'll wait to have you get back on it. We're fine.
My apologies for that. I
We're
thought my
fine.
battery was plenty charged. Apparently it is not. We're full technical.
Some things drag more battery than others.
Are we still live?
Yes, we are.
I'm just. Long.
Always, it's, yeah.
All right. Ooh, I'm still on. All right. Take 3. Thank you, Kiki. And then we I talked about eligibility, but then before I was talking about what is covered. Now, like I mentioned, we have our optional and our mandatory. So when I talked about before, and I said you've seen one Medicaid program, you've seen one Medicaid program. Well, states not only have different eligibility in terms of mandatory and optional. Vermont has chosen to be include more optional in terms of eligibility, which is part of why we have a higher Medicaid population, percentage of people on Medicaid than other states. But we also have the services. So on the left side, you'll see these are mandatory services. These are services that if we offer Medicaid program, whichever state does, we have to offer them. That's inpatient, outpatient, home health, lab, transportation, etc. Then we have our optional. So these are services that Medicaid is allowed to cover and receive our matching dollars, or bless you. But just every state is different. So for instance, you'll see Cairo on there. And in the time I've been here, I've seen Cairo come and go. How many times? Multiple times. Dental is also one that not every state offers. So again, if you do one Medicaid program, you see one Medicaid program. This is something that I want to just touch upon briefly, and I'll get a little bit more detail when I do Medicaid. Global Commitment is the name of our agreement with the federal government to operate our system. You'll see the term CMS, that stands for the Center for Medicare and Medicaid Services. They're our federal partner and who we've worked with. Global Commitment Health is the full name, but it's Global Commitment. And basically what it is it's what's known as a Section 1115 demonstration project, also often referred to as a waiver, because in the federal statute, it waives certain provisions of the Medicaid law that gives states flexibility to encourage innovation to do certain things. So when you hear global commitment, that is what's known as a waiver And what it basically is that every state, I think I have it somewhere else. Oh yeah, at least 47 states have at least one or pending waiver. And this is from 2020, but numbers may have changed. Some states have multiple waivers, and it might be a small waiver, like for for elderly folks, or to help people in nursing homes, or for mental health. And basically, what it does is it's basically a way for states to have more flexibility than we would under traditional Medicaid rules. In order to do that, the federal, there's all kinds of parameters you have to do to apply to the federal government. We have to have a plan. And it also, most importantly, has to be budget neutral to the federal government, which means that it wouldn't cost the federal government any more money to do this than it would in the absence of it. And what we get in return is we can do things like expand services, provide more. So global commitment in Vermont. Well, Vermont is the only state that I know of that administers its whole Medicaid program through a single waiver. And the idea behind that is, and these waivers are always a signal of a particular state's priorities and values. So Vermont has chosen it wants to do more, it wants to cover more people within parameters. There's things called terms and conditions that allow us to do certain things, but ultimately it's an agreement with the federal government to administer our Medicaid program outside of the traditional rules, but within the parameters of acceptance with them. And it allows us to spend money, Medicaid match money, on things that we would not have been able to spend in the absence of the waiver. And I'll get into a little bit more detail about what that means and what those things are. But every state has a waiver in their Medicaid program. But a lot of the things that we do in Vermont, a lot of the services that we do, including mental health and addiction services, we're able to get Medicaid match on these things. Otherwise, it would be pure state dollars, or we wouldn't be doing them at all. And we have these things called investments, which I'll get into the details of, but that's $127 million in services that we are getting Medicaid match on, but within the absence, just to give you a sense of this. And I'll get more into what global commitment is tomorrow when I come back. I also want to quickly talk about these things called dual eligibles. And these are folks that are eligible for both Medicare and Medicaid. Medicare is the payer of first resort. So when you saw the chart earlier of Medicare and Medicaid, these folks that are these are dual eligibles, they would count under the Medicare part of the pie. There's about 22,500 of these folks. This is 2024, so this is pretty up to date. The reason we care about them is that they are very, very expensive population because they're all older. AHS, the state of Vermont, spends over $600 million per year on health care and other support services for these folks. So just to give you a sense, so there's a lot of programs that are targeted at dual eligibles to try to get them support, to try to help them stay healthy, try to control the cost, but also increase their quality of life.
So the $600 million is all of that money, Medicare, Medicaid?
No, it's all.
Some of it is.
It's a mix of. This is what we pay the Agency of Human Services.
Right.
So it's a mix of state dollars and Medicaid.
And some
because some of it's matched.
Might be for long-term care or some home care services.
This is money appropriated by the state, so it wouldn't be any Medicare.
Yeah.
And it would be a mix of some special fund.
Yeah.
Medicaid, I almost did it myself. And then some other stuff that we just do pure state dollars on.
Yeah.
For different services, but it's just across the whole spectrum of services, whether it be the Department of Age and Independent Living, or health department, or whatever. This is all those services.
So the healthier we keep our population, the better.
Yeah. These folks are within your jurisdiction.
Yeah.
In 2020, Vermonters spent $6.4 billion on healthcare. Again, this is 4 years old now, this data. I suspect we're probably surpassed the $8 billion mark. Hopefully we can get some data on this soon, but that would be my suspicion. Nonetheless, so Medicaid accounted for about 27% of all spending Vermonters at that time. I'm suspecting the number hasn't changed a whole lot. It's gonna be within that portion of the pie chart. I flag this because, this obviously has implications to the state budget. As you can see here, we have a total in 2024, our total bid appropriation was $8.56 billion. 2.3 billion of that was Medicaid. Now that's all funds. You're gonna hear me say the word gross a lot, and it's not because I think something's disgusting. That was a joke. It's because it's it is, when we say gross, we mean all funds. So it's state dollars, it's special funds, it's general funds, it's total. So this is all total gross state spending across all funds. Yes, Chair.
While we're doing this, it occurs to me that we're getting into a lot more detail and the sort of financial piece that maybe I'm going to ask you. Would you suggest a 5-minute break at this point? And then come back and maybe scroll back to the dual or to just dive in here again? Would people like that? Because I'm feeling that
Yeah,
might be
That'd be
helpful.
great.
We can take a break, that's fine.
Do you mind? Oh, so let's take a little break and we're gonna come back at